Again, good morning, good afternoon, good evening, everyone, and thank you for joining us today and welcome to this webinar. First, let me introduce myself. My name is Natsaina Tuvas-Mbavak. I am a senior behavioral designer at IDS42, and I will be presenting this webinar with you today. That is along my colleague Abigail Salman, and also my colleague Sarah, who will monitor the chat. And we are also joined today with our valuable partners from Nigeria and Cameroon. They will present some of their work with us today. And for today's webinar, we will navigate together a newly developed resource on closing the COVID-19 vaccine uptake acceptance gap among healthcare workers, especially in low and middle income countries. Please, during the presentation, keep your camera off and your microphone off unless you are called on to speak. Slide. So let's walk through together today's agenda. So first, we will look at the context of what brings us here. And secondly, we will see together some behavioral insight into the acceptance and adoption of the COVID-19 vaccine among healthcare workers. Third, as this webinar focuses on the newly developed resource, in this section, we will navigate through it together. And fourth, we will invite the partners from Nigeria and from Cameroon to present some of the approaches that they have been implementing in country to increase the vaccine uptake. And at the end, we have the question and answer session. However, during the presentation, if you have questions, reaction, comments, feel free to raise them in the chat as we will try to address them at the end of the webinar. So without further ado, let's tackle the first part of this webinar on what leads us here. So the context, next slide. This particular initiative falls under the USAID flagship social and behavioral change program, namely Breakthrough Action. And IDS42 with Breakthrough Action Consortium have been contributing to the effort on increasing the COVID-19 vaccine uptake in multiple countries around the world. And several of those activities have focused especially on supporting uptake among the priority group population of healthcare workers. Why did we focus on healthcare workers? We all know first that for their role of as frontline workers, also as their potential influence on the public attitudes and behavior when it comes to vaccines, it is really important that they got vaccinated. But yet many of them are not vaccinated still, and that is despite of the progress in vaccine supply and demand generation effort around the world. Slide, please. So this particular work focuses on synthesizing and disseminating lessons learned around health workers' vaccine uptake in low and middle income countries. And this synthesis reflects insight from Breakthrough Action's COVID vaccine demand generation effort, which includes a formative research and co-design activity in several Breakthrough Action countries where we develop behavioral solutions. We had also a literature review and analysis to identify other promising ideas and approaches to the use of the vaccine. Third, we had several discussions with our partners about their perspective of their work, and we were building on the knowledge gained from that activity and also from the activities of other partners to share lessons learned about the influence of the on healthcare workers' vaccine behavior. Slide, please. So the result of this effort is a synthesis brief. And in addition to that, there is a companion piece that goes into more details on designs and implementation consideration on 4 specific approaches that we co-created and user tested in several breakthrough action countries. And for today's webinar, we are going to walk through this synthesis brief to share some behavioral insight and to demonstrate how to use and explore this newly developed resource. Slide, please. So this particular synthesis brief is structured to help the reader to first understand what factors might play the biggest role in health workers' decision when it comes to vaccination. And secondly, to use that knowledge to choose and adapt solutions and designs with greater likelihood of impact. So at first, you will see the behavioral insight of health workers' vaccine uptake. And the second part of the brief, you can see solutions and approaches bucketed by design aim. And today's webinar is also structured similarly. Slide, please. Now that we have understood the context, we will now explore the behavioral insight. And for that section, I will hand it over to Abby. Abby, over to you.
Thank you so much, Najina. So as Najina said, the brief starts with a synthesis of behavioral science insights into healthcare workers' vaccination decisions. But first, just wanted to take a step back and ask, why is a behavioral science perspective important? As Najina said, healthcare workers have a unique position as both frontline workers and medical professionals. They need to manage client concerns, but they often have questions of their own about the vaccine as well. And health workers, like all of us, are strongly influenced by what is around them in their environment. For example, they might be influenced by visual cues in their workplace, at facilities, the actions of their peers, or their previous experiences. And all of these factors influence how they think about the vaccine, how they weigh decisions, and whether or not they will take action to get vaccinated. And so a behavioral perspective helps us to consider all of these factors in healthcare workers' environments that influence them, and in doing so can illuminate new opportunities to promote uptake. So to see how this plays out in practice, I want us to consider how the environment might affect healthcare workers. So I would like all of you to bear with me and imagine that you are a health worker yourself living in potentially a rural area with low overall vaccination rates. And you can fill in the blank in your heads in terms of what type of healthcare worker you are and any other characteristics you might have, such as your age or your years of experience, things like that. So as this health worker, various factors might influence your decision to be vaccinated. So let's consider that your environment might look like this. During the peak of COVID-19, people didn't seem to be as sick as compared to normal malaria season. In your environment, you're also often receiving updated guidelines that highlight new and adverse effects and give information about additional recommended doses that are becoming available. Additionally, your community largely trusts international public health authorities when they describe the vaccine to be safe, but the closest vaccine site to you, often has an inconsistent stock of vaccines, and you're not sure when those are available. So consider that as your whole environment. And I want to ask you some questions from the perspective, again, as if you were this health worker. So in a minute, we're going to show some polls on the screen, but just know that there are no right or wrong answers to these questions. Again, you're responding as an individual, so we'll kind of expect to see a range of responses. Rebecca, can you launch the first poll, please? All right, thanks for sharing the results of the poll. So you can see here that based on this environment, there's kind of varying ways and varying levels of concern you all might have about if something bad would happen to you if you took the vaccine. Now I want to ask you a second question as if you were a health worker in this environment. So there will be another poll on your screen. All right, thank you again for sharing the responses. And you can see here, most people voted that they think there would be serious hassle or moderate hassle to getting the vaccine in this context. So based on all these considerations and how if your level of if you think something bad might happen to you, how much hassle you anticipate, now I want to ask a third question. All right, thanks so much. So again, how likely would we all be to get vaccinated if we were a health worker in this context? There are varying responses of how these different influences would affect individuals in this context. So now let's consider a different context. Imagine now you are a different health worker living in a totally different context. Maybe it is an urban context this time. Maybe some of your other characteristics are different as well. So imagine you are a different health worker now. And there are various influences to consider in this environment as well. So in this environment, consider that the government has a history of corruption, a history of taking money from foreign entities for political favors. And in your environment, clients have often asked you many questions about the safety of the vaccine, and there's a high penetration of rumors that circulate on social media. But unlike the last context, vaccines are offered at most health facilities in your environment, and vaccine cards are also available that people may need to travel. But even vaccinated people you saw become sick when the new variant of the virus arrived. So let's consider similar questions again. And remember, there are no right or wrong answers. Again, just answering from the perspective of a health worker living in this environment. We'll give a few minutes for this one since there are 3 questions. All right, thank you for sharing the poll results. So we can see here that most people in this environment would feel that they have little trust in the government or vaccine makers, but there's varying responses in terms of how beneficial people would anticipate the vaccine. And based on all of those considerations, again, we see very variable rates of how likely people would feel, how likely they would be to get vaccinated. So thank you all for playing along with these polls. And hopefully what was made evident from these is that there are many different factors that can influence health workers at the same time, influence how they think about the vaccine, how they weigh decisions, and whether or not they take action to get vaccinated. And during our synthesis of insights, we attempted to organize and make sense of all of the different factors that influence health workers. And we came to organize them into 5 distinct buckets of cross-cutting factors. So from the perspective of a health worker, these include whether health workers are concerned that they'll get infected with COVID-19, if they think the vaccine will have real benefits for them, if they trust the government and vaccine makers and trust that they have their best intentions in mind, if they're concerned that something bad might happen to them if they do take the vaccine, and if they can get the vaccine easily without hassles or major disruptions to their life. And again, health workers use these factors to weigh up the risks and benefits of getting vaccines, even if they're not doing this consciously, even if this is an unconscious weighting. And also many of these factors can affect health workers at the same time. And as you saw in the polls, the same factors can influence health workers very differently from one another. So efforts to support vaccine uptake should consider a broader context when identifying opportunities for design. And now we're going to go through each of these cross-cutting factors in a little bit more detail now. So the first set of factors is related to whether health workers are concerned about infection with COVID-19. But what kinds of things influence whether or not they're worried about getting infected? Some examples include whether healthcare workers are already following protective measures, or how healthy they perceive themselves to be, especially as compared to their sick patients. And additionally, health workers might also be less concerned about getting infected because the pandemic has already been going on for a few years already. They might assume that because they've stayed safe for so long, even after seeing many sick patients, they'll be okay without the vaccine. They might assume that they've sort of passed the window of time where they would get ill. But other health workers might perceive greater consequences of getting COVID-19 for the same reason, because they've seen many people getting sick. So again, similar environmental factors might influence health workers differently. In addition, health workers, in addition to them weighting their risk of getting sick, they're also considering whether the vaccine has benefits for them. And one reason they might do this, consciously or not, is because health workers are generally provided with the most up-to-date information about vaccine schedules, vaccine brands, and efficacy rates. And while this is necessary because they see that the recommendations are constantly changing, it can lead health workers to perceive lower benefits of getting vaccinated now, so they might delay their vaccination. And similarly, at the start of the pandemic, health workers may have wanted to delay their vaccination as well in favor of waiting for more choices, new vaccines to become available. A third group of factors which influences how health workers weigh up the decision to get vaccinated are factors related to how much trust they have in the government, in vaccine manufacturers, and as well as how much reciprocity they feel towards those actors. One really interesting insight that was continuously elevated in our synthesis was that many health workers, particularly in low and middle income countries, often see patients with severe cases of endemic diseases such as malaria or TB, but these health workers have yet to personally see cases of severe COVID-19, and official case rates remain quite low. And this can lead health workers to question why so much official attention or funding has been devoted to COVID-19 over other seemingly more pressing health challenges in their contexts. And this can feed into distrust of the government and also skepticism around the intentions of vaccine manufacturers. Health workers also might be concerned about the negative effects of the vaccine. For example, they might be particularly aware of adverse effects, again, because of their role in sharing information with clients and with the public, or they might hear rumors or about the vaccine or conspiracy theories like all of us, or they might be skeptical about the time it took for the vaccine to be developed. These examples probably aren't new to anyone, but they remained important features during our synthesis. And finally, our last set of factors points to the fact that even when health workers have a strong intention to get vaccinated, they still might be heavily influenced by whether or not they can easily get the vaccine without hassles or major disruptions to their lives. For example, they might know that supply remains unreliable at some vaccine sites, so they anticipate stockouts at these sites and decide not to take their chances by going to a site when the vaccine might be unavailable. Also, as health workers commonly advise clients that they might experience some side effects after taking the vaccine, they're particularly aware of the possibility that getting the vaccine might interfere with their ability to work for a few days. And as we all know, health workers have very busy schedules and many facilities operate with limited staff. So the risk of experiencing these side effects or not being able to work might not seem like an option to healthcare workers. So that's a very quick high-level summary of some of the behavioral insights that we share in the brief, and we go into much more detail through each of those categories and buckets. Although these buckets are just a way of categorizing the insights that we gained from our synthesis, and though many of these factors are also interconnected with one another. So we hope that these insights can be used to inform choices of what approaches to take to target healthcare worker behavior. And before we move on, we want to do one last poll for everyone, just to hear from your perspectives. Which of these considerations do you think have the biggest influence on healthcare worker behavior in your context? All right, thank you for sharing the results on the screen. Yeah, we see some variation here as well. But interestingly, it seems like 50% of people said that a big influence on healthcare workers in their context was this piece around making it easy for people to get the vaccine. So can healthcare workers get the vaccine easily without hassles or disruptions to their life? So thank you all again, and I will turn it over now to Najina to walk us through the brief and how you might use these insights to consider solutions for your context.
Thank you so much, Abby, for that. And slide, please. So during this part, we will walk through the section on how to consider approaches or solutions based on our context. It's crucial to apply the right solutions to the relevant problem, that is to maximize impact. So the synthesis brief organizes a set of promising approaches and solutions into 4 design aims for supporting vaccine uptake to make them easier to consider and prioritize for a specific context. And each design aim has a simple behavioral rationale, considerations for implementation and adaptation, and illustrative example. Among the 4 design aims, we have first, to make it easy. You could consider making it easy if health workers in your context still face challenges related to the vaccine access and availability, or they perceive hassles in the process of getting the vaccine. It is especially important for people who are otherwise ambivalent about getting vaccinated, or they just don't see it as a priority to make the effort. Secondly, the design aim is to build knowledge and skills. It is to consider when health workers still have questions or gaps in understanding about the COVID-19 vaccine or the development process, the adverse effect on how to consult the clients. The third design aim is to build confidence and trust. It is to consider if beyond the lack of information and knowledge, health workers have other concerns caused by misinformation and or distrust, either towards the vaccine itself or its intentions, or the capacity of the authority who manages the vaccine process. And fourth is to prompt action. You could consider this design aim if health workers might not strongly oppose to the vaccine, but they don't see compelling reason to act now. And today we will focus on one particular design aim, and to choose one of them, there is a poll appearing on the screen, poll number 6, please. And you could vote based on the context of health workers in your setting. What is the most reasoning design aim that you want to deep dive into during this webinar? Rebecca, Would you please share the result? All right, so we have the winner, which is prompt action. Almost the majority of us voted for it. So let's deep dive into it. So the design section of the synthesis brief describe a set of approaches and solutions organized by design aim that we previously saw and which appears on the screen as well. So now that we have chosen, we just click on the prompt action explore button. And once you click there, you land into this specific page where you find different approaches under this design aim. Health worker may procrastinate getting the vaccine if they feel no urgency or perceive no benefit for getting the vaccine. So these approaches nudge health workers to act now by creating a benefit of getting the vaccine or creating consequences of not getting vaccinated. So to prompt action, we have 4 bucketed approaches. First is incentives, which aims to provide immediate benefit of the vaccination. Second is the mandates, which aims to create downsides of staying unvaccinated. Then making vaccination visible, which leverages social influence and pressure. And lastly, there is a peer referrals, aiming to leverage personal outreach and social accountability. To look into the illustrative solutions under each of these approaches and based on the most relevant influence in your setting, you can click on the approach for more details. So for the sake of this run through, we will just click on making vaccination visible. Let's try to click on explore button. And once we click there, we will land into this specific page. And here we have solutions for vaccine visibility. And raising the visibility of peers who are vaccinated can help to prompt conversation about the reasons and the reasons why they are getting vaccinated and also their experience of doing so. And those can create opportunities to encourage others. Making it easy to spot vaccinated peers can also elevate perceptions of how common a vaccination is among peers, and those could motivate health workers who are otherwise ambivalent about the vaccine, but they are sensitive to being seen as different. So for each solutions, you can see a brief description of the approach and an illustrative example. And for this particular solutions, we have 2 examples, which is the poster from Cameroon and pins from Liberia, which are featured here. And each of the example or illustrative example featured here, we noted, highlighted considerations for implementations and adaptations to make the solutions respond to the setting where it would be adapted and used. And to explore more solutions or design aim, you could click back into the specific approach or the design aim, or you could just click back into the design menu page. And when you click back into the design menu page, you will land into the initial page where you could just choose which design aim you want to deep dive into. Slide, please. If you consider to implement one or some of those solutions in this brief, there are some tips that we highlighted. First is to leverage input. That means deciding which solutions and approaches to choose and how to tailor them locally with health workers' contribution and also stakeholders' input. Second is to leverage network, meaning amplifying intervention effect by increasing visibility to reinforce social norms with channels that encourages or facilitate interpersonal communications and influence, whether it is through family, peers, professional, or virtual network. Third is to leverage identity, leveraging identity of health workers as influence in the public behavior and also as their roles of safeguarding the public health. And lastly is to considering integrating or pairing some approaches, and that is to maximize impact. Slide, please. Now that we have covered how to navigate the synthesis brief and how to explore the solution section, now we are going to give the partner the floor to share some of the approaches or solutions that they have been implementing in country. Slide, please. So the first partner we have today is Mukwele Cynthia. She's from the Ministry of Health from Cameroon, and she has been involved in working in the rolling out of the focus group discussion in Cameroon. And today she's going to share about that specific approach. Cynthia, thank you for joining us today, and thank you for being here. Over to you now.
Thank you, Madam Najina, for giving me the floor. In Cameroon, the approach we used to close the gap for the COVID-19 vaccine uptake was a focus group discussion. And in March 2021, a quantitative prospective study on the acceptability of the vaccine against COVID-19 was carried out by EPI, that is an expanded program for immunization under the Ministry of Public Health. And we obtained the results as follows, that out of every 2 health personnel, 1 agrees to be vaccinated against COVID-19, giving us a percentage rate of 50.8% as compared to the acceptance rate of 63.7% among community leaders. We also identified the following factors for vaccine hesitancy, such as the efficacy of the vaccine. Many people doubted the efficacies because we had different types of COVID-19 vaccine, and also a negative perception of its rapid development, since people are aware that for vaccine development, we need at least 10 to 15 years to develop a new vaccine, unlike the case with COVID-19 vaccine that took just less than 1 year. And also another factor identified was the use of traditional treatments. We know during the peak, that's at the peak of COVID-19 pandemic, many traditional practitioners came up with many herbal solutions, of which the population believed that they were more effective than the vaccine, so no need for them to take the vaccine. As objective, our main objective was to determine the underlying reasons for the low level of acceptance and also the involvement of promoting COVID-19 vaccination by healthcare workers. Of course, we as healthcare workers cannot be sensitizing and encouraging the population to take the vaccine when ourselves we are refusing to take the vaccine. Slide, please. So to carry out this activity, we applied the following methodology. Firstly, in all the regions in Cameroon, that's the 10 regions, we selected 10 health facilities per region, of which 10 healthcare workers were chosen per group. And we used a guide with approximately 10 to 15 questions to carry out this study. The participation was also anonymous. It means that we did not use real names of the participants, but rather their nicknames, because this is to avoid fear during their responses and to give them confidence that their responses will be confidential. So this also helped us in our transcription process, because there was also a recording session at each focus group discussion. And also, it also helped us in the transcription because we know who is talking at a particular time. And when we move to a particular session or a particular group, we always go along with a vaccination team. So at the end of each focus group discussion, there is on-site vaccination for those who volunteer or have a change of perception after the discussion. As results obtained, we had the following concerns raised. We realized that 52% of the population were afraid of the vaccine outcome, 30% were not sure about the vaccine quality, 25% did not even believe that the COVID-19 disease is existing, and 20% said it was a one man streak, while 20% also concluded that it was a mark of the beast, because they said there'll be mark of the beast at the forearm, at the arm and the forehead. But we had to debunk all these messages during the course of the discussion. And at the end of each focus group discussion, we realized that at least 3 out of 10 healthcare workers got vaccinated. Slide, please. Okay, as lesson learned, we learned that it is very important to engage healthcare workers in designing health interventions through dialogue. So in such projects or interventions, it is not always good to centralize the activity, but rather decentralize them at the level of the regional level, the district level, the health area level, and why not the health facility level. So it is important to engage every stakeholder to get the ideas of everybody on board. The implementation consideration were as follows. We need to scale up the number of sessions to have more deep insight about the project being carried out. We also need to have such sessions even before the vaccine introduction. It means that we should not only do advocacy or sensitization doing maybe a vaccination campaign, but rather we should carry out this even before the introduction of the vaccine. And lastly, we need to hold sessions according to medical code. It was realized that when we merge medical personnel, for example, merging the medical doctors, the lab technicians, the midwives, and the nurses, it prevented some to really express themselves, maybe due to shyness or they are afraid of their responses. But if we rather like separate them into their respective calls and carry out the focus group discussion per call, it will give a better understanding and expression of each participant. So that's our approach in Cameroon to close the gap for the COVID-19 uptake. Thank you.
Thank you so much, Cynthia, for that interesting presentation. And now we welcome Sarbian Sheni. She's from the Breakthrough Action Nigeria, and she was involved in the user testing and finalization of the vaccine awareness card, which tries to close the knowledge gap among healthcare workers and prompt vaccination. Thank you for being here, Sarbian, and over to you.
Thank you, Najina. Permit me to speak without my video. I've had to keep switching my internet to be on this call. So I will go right into it. In Nigeria, we hosted a marketplace of designs in early May or late May. In May, where we considered a set of behavioral designs that we could adopt in order to improve uptake of COVID-19 vaccination in the country. And putting it down to the vaccine awareness cards, initially, it was an interactive card game that is used to help healthcare workers build their understanding of the COVID vaccines, the new vaccine schedules, basically updated information about COVID-19. And it was supposed to be such that players would throw dice, and depending on the number of seeds on the dice, they read a corresponding question and work together to answer it. However, when we did user testing across different facilities in the Federal Capital Territory of Nigeria, we had to drop the game format and we modified the content to include more information that was contextual for Nigeria, and based on even the request and their feedback from the user testing. And the range of topics that we included were building resilience to misinformation, encouraging healthcare workers to prioritize their own well-being, and overall, the aim of this approach was to clarify on outstanding questions that healthcare workers had about the vaccine, and also boost their confidence in communicating about the vaccine and doing counseling for clients. So based on other studies that were done in Nigeria, we found that there was a knowledge gap, and because of the changing nature of information around COVID-19, not a lot of them were confident to communicate about it to clients. So if you look at the mock-up, you would see the new, or how we modified the cards to become COVID-19 vaccine awareness cards that cover a series of topics that include, oh, what do I do when I miss my vaccination, I miss my second dose, how to address stigma, and healthcare worker resilience as well. Next slide. Right. So how the cards were received by healthcare workers. During the user testing, the content themes resonated with them. They found the cards fun and informative. And like I said earlier, they requested some more cards on information that they deemed necessary at the time. So the cards were redesigned and produced. So next slide, so that I'll talk about implementation. Yes. So Breakthrough Action Nigeria has integrated these vaccine awareness cards as a result in our healthcare worker scope, where we focus on healthcare workers as an audience. And another approach we use is we've been conducting a series of training titled Building Trust and Empathy Among Healthcare Workers for Client-Centered Communication. And while those trainings are ongoing across different states in the country, the awareness cards will form part of the materials that will be given to participants who are mostly healthcare workers and people with direct influence, for example, in the Ministry of Health. And then for implementation, how is it going to look like in the facility? The cards are supposed to be kept in a central location where healthcare workers are free to go there and refer to it when they need information or need something to look at that provides all of the contextual information on COVID-19. If you look, you'd see an example of one of the topics we added, which is healthcare worker resilience, that talks about how healthcare workers are feeling and how work could impact on their well-being and how to manage that. And then an advice for implementation is leveraging partnership and identifying other opportunities in collaboration with partners. So Breakthrough Action Nigeria will leverage a relationship with service delivery implementation partners across different states to identify facilities and prioritize distribution to them. So as this has become a resource for our healthcare worker scope. Thank you.
Thank you so much, Sarben, for that presentation. Thank you both for highlighting the work that you've been doing in the country. And those are just example of approaches, solutions that were included in the brief as well. And for example, the focus group, all of them, the focus group discussion and the vaccine awareness cards, they fall under the build knowledge and skills, as well as the build confidence and trust design name. So if you want to know more, explore the newly developed brief. So the presentation ends here. And now, slide please, we will open up for questions and answer of what we've just discussed on the behavioral insight on the solution section, but as well as from the partners' presentations. For that, Sarah, do you know if you have some questions from the chat for the presenters?
Sure. While we wait for any other questions to come through, there was one from Heather Abby about, did you find that other providers or colleagues' opinions about COVID vaccines or vaccine status played into their behavior?
Yeah, thank you, Sarah. And Sarah, Najina, or other presenters, please feel free to chime in. But I think most definitely, as Sarah said in the chat, in a few ways, I mean, hearing stories from other healthcare workers or concerns about the vaccine just elevates those concerns for healthcare workers and makes them question the vaccines themselves. But also, I think a big thing that we found too is, that the behavior of getting vaccinated isn't always visible to health workers. So health workers might not know which of their colleagues is or isn't vaccinated as well. And having the perception of that your colleagues aren't vaccinated can lead you to distrust the vaccine a little bit more, even if some of your colleagues are vaccinated. So as Sarah shared in the chat, that led us to some of the approaches around making vaccines more visible or increasing peer referrals or things like that to show healthcare workers which of their colleagues were in fact vaccinated. I don't know if anyone else has other things they'd like to add to that, or any of you all as well as participants, if you have experiences you want to share.
Thanks, Abby. We do have some questions coming through. So Pamela, do you want to ask your question?
Thank you for giving me the opportunity, but I'm really the African continent to address. So my question actually goes to the last speaker. I wanted to find out, with the cards that are being used in Nigeria, was there a way to measure an increase in measure an improvement in knowledge in the healthcare workers following the exercise? Thank you.
Sarbian, I think that was a question for you.
Yes, thanks, Pamela. So we actually have just rolled out the first phase of the cards, and hopefully we would do another, or would feature in another webinar where we can talk about the results and measure how the cards have increased knowledge of COVID-19 among healthcare workers.
Thank you so much. I just wanted to add that we also carried out what we did, which was also very helpful, is to make presentations on frequently asked questions, which we kind of shared with healthcare workers. And these were popular questions that were raised in the community. So it helped them to really understand or to know how to debunk some of these myths and rumors that they saw in the community.
Thanks, Pamela and Sarbian. A similar question coming through from Donna. Has there been any measurement to understand which methods or tactics are most correlated to uptake? I can answer a bit from our experience putting together this synthesis. It was very hard to find any publicly available research in terms of what methods or strategies have been effective. There's more research on insights around the barriers, but I will open it up to see if anyone else, any of the other presenters or participants are aware of any research in terms of which methods work best. Martha, you have your hand raised.
Yes, thank you for giving me the floor. I think as a participant and someone who also work together with Cynthia and Pamela with health care workers, I think the method that works best is when you get to educate them, because one of the reasons why there's hesitancy among this community, among this group of persons, is because there's a gap in knowledge. So from our own context, it has been proven that when that continuous education makes them to easily have that decision whether to take the vaccine. In most cases, yes, to take the vaccine. So continuous education with the health workers, independent of their core, gives them that opportunity to know exactly what is happening and to take that informed decision. Thank you, and over.
Thanks, Martha. There's a question in the chat from Ebunlomo Walker asking about any segmentation of health workers for more targeted action. I know, Cynthia, that came out as one of the recommendations from your focus group discussions. Do you want to say a little more about why you suggested separating them into different groups of health workers?
Okay, thank you for giving me the floor. After carrying out the focus group discussion in the first health facility where the different calls were mixed, we realized that participants were not free enough, especially those that were at the lower calls to express themselves. So in subsequent or in the other health facilities, we decided to specify, for example, the medical doctors and nurses, as we move from one health facility to another, we specify to have a wider idea or impact on the approach. Okay.
Thanks. Question from Gregory, hand raised.
Yeah, I maybe an observation about best practices from my review of the literature and from the looking over a number of interventions that USAID has supported across Africa. What you call the dialogue approach to interventions, and I would call participatory, but it's the same thing, I think. When health workers are actually participating in the design and implementation of vaccination campaigns and other interventions, it seems like that has a very positive effect on their own confidence about the vaccines, and it plays to their image, their self-image as models for the community, and that seems to be a technique that seems to be highly effective.
Thanks, Gregory. It looks like a similar comment in the chat from Pamela as well. Sarbian, you had a question around the Cameroon focus groups. I'm curious as to how you were able to host the focus group discussions with how healthcare workers are often engaged, what strategies were used in the planning phase. Sarbian, did you want to add anything to that question, or should we turn it to Cynthia?
Yeah, I'm just saying how healthcare workers are often busy, and you know how the schedules can be. What strategies did they use to engage them, and how did that go?
Okay, thank you very much for that wonderful question. To go out with this, to carry out this activity, considering the fact that healthcare workers are very busy, we sent letters ahead of time to the different hospitals or health facilities that were to visit. And we instructed the heads of the health facilities to give us their available time when they think most of their staff will be free for us to discuss. So each health facility has its own time where we were the one meeting them at their respective hospitals to have this focus group discussion. So it was easier for us to carry on with this because since personnel healthcare workers, they always work in shifts, though it was easier for them to identify those that will be free at a particular time of visit. Thank you.
Thanks, Cynthia. Abby, can we go to the next slide to see? We are curious to open it up in the last few minutes to see if anyone has anything particular to share around challenges that are sticking out, and any solutions, other solutions you've tried that have been successful, in particular focusing on healthcare worker vaccine uptake. Pamela, go ahead.
Okay, thank you so much. I just wanted to go in the same light to share our experience in Cameroon. My region is the last, has been the last region for COVID in terms of COVID-19 vaccination. And we've had a lot of hesitancy especially from healthcare workers. The uptake was really poor. And there was this project we implemented that required increasing the scale of health facilities involved in COVID-19 vaccination. It meant training more people, it meant involving more healthcare workers. And we realized that after doing that, each healthcare worker felt who had no knowledge, limited or little knowledge on COVID-19 vaccination, had improved knowledge, and they as well were able to influence their entourage and influence their families as well. We had healthcare workers who were in charge of plantation workers, who were in charge of private institutions, who were in charge of Catholic institutions and all the like. So this contributed in vaccination uptake overall. We noticed that many of them decided to openly get vaccinated in front of their friends, in front of their families, in front of their colleagues. And we moved from 12,000 people vaccinated in the last COVID-19 vaccination campaign to more than 95 people vaccinated in this COVID-19 vaccination campaign. So I think that these two play a role when we implicate, when we involve, when we make them have ownership of the activity. They go as well to encourage other people to receive the vaccine. Thank you.
Thanks, Pamela. Next slide, Abby and Jenna.
Thanks so much for your interesting comments and questions and discussion. And for this particular scope, we share on the slide the link where you can, the resources on the chat, the link actually, but on the slide, the resources for the two brief and design guide that we developed, where you can go and explore. And they have English version and the French version as well. So here ends this presentation. Thank you for being with us today and having this very interesting conversation. And before we wrap up, you are invited to complete the poll which appears on your screen. And we look forward to contacting with you with the recording and the resources via email on the follow-up email. Thank you all and have a good rest of your day.